Good day, everyone. First of all, I would like to thank the UPPGH Division of Hematology for this opportunity and congratulations in advance for this 10th postgraduate course. So today I would like to talk about how do we deal with severe thrombocytopenia. We will be reviewing the etiologies of severe thrombocytopenia and give an overview of the basic approach to diagnosis, to review the indications to suspect red flags in emergent conditions presenting with severe thrombocytopenia, and to provide an overview of the basic indications for platelet transfusion. So thrombocytopenia is defined as a platelet count below the 2.5th lower percentile of the normal platelet count distribution. Results of the NANES 3 support the traditional value of 150,000 as a lower limit of normal. However, platelet counts between 100 to 150,000 do not necessarily indicate disease if they have been stable for more than 6 months. Adoption of a cutoff value of 100,000 may be more appropriate to identify a pathologic condition. So thrombocytopenia can be classified as mild, moderate, severe. Mild being a platelet count above 70,000, moderate platelet count 20 to 70,000, and severe with a platelet count of less than 20,000. Although easy bruising occurs in patients with platelet counts less than 50,000, and spontaneous life-threatening bleeding can be expected in patients with platelet counts less than 15,000, bleeding symptomatology is largely determined by comorbid conditions affecting platelets or the coagulation system. The mechanisms and etiology of thrombocytopenia in general can be categorized as increased destruction from immune causes like immune thrombocytopenia, heparin-induced thrombocytopenia, drug-induced antibodies, HIV, post-transfusion purpura, connective tissue diseases, and thyroid disorders. Increased destruction by non-immune causes would include DIC, PTP, HUS. Decreased production would include hematologic malignancies, bone marrow failure states like aplastic anemia, ineffective hematopoiesis such as myelodysplasia, marrow depression by radiation, chemotherapy, alcohol, or other medications, infections such as measles, HIV, and bone marrow infiltration by metastatic cancers or infiltration of the bone marrow by infective causes like tuberculosis. Vitamin B12 and folic acid deficiencies can also cause thrombocytopenia as well as pancytopenia. Splenic sequestration, wherein you have hypersplenism, can also cause thrombocytopenia. So there are no specific laboratory tests that can conclusively identify the mechanism of thrombocytopenia. A thorough history, clinical examination, and blood exam remain the initial means of diagnosis. So this is a proposed approach to thrombocytopenia. First question we have to ask is if it is real. This can be evaluated by examining the peripheral blood smear. And when you see platelet clumping, then it might be artifactual or through pseudothrombocytopenia, which is found in 1 in 1,000 blood test results and can be a result of platelet aggregation, collection errors, or platelet satellitism. An unexpected result, therefore, warrants a repeat test. On the left is what normal platelets look like in the PBS. In the middle is platelet satellitism and platelet clumping on the right. In vitro clumping of platelets can occur when EDTA is used as an anticoagulant in the test tubes used for blood collection. This is thought to result from alteration of platelet surface glycoproteins when incubated with a calcium chelator like EDTA. As neither citrate nor heparins produce this phenomenon when used as anticoagulants, simultaneous collection of repeat blood in EDTA as well as citrated test tubes will confirm pseudothrombocytopenia. Once we have confirmed that the thrombocytopenia is real, we then ask whether it is of new onset. So the previous blood results of the patient should be reassessed. A low platelet count may be normal for the patient and not represent illness. In addition, a chronically mildly low platelet count of 50 to 100,000 in a stable asymptomatic patient with no other cytopenias can safely be monitored. Confirm if the thrombocytopenia is isolated, meaning the full blood evaluation is otherwise normal and there are no red or white blood cell abnormalities on a peripheral blood film. An abnormal blood film with the presence of blast cells or any dysplastic changes warrants urgent referral, and we'll go through this in a while. So isolated thrombocytopenia has a limited differential diagnosis. The two most prevalent etiologies are immune thrombocytopenia and drug-induced thrombocytopenia. For case 1, you have a 35-year-old female with no known comorbidities who came in due to a 2-day history of epistaxis. She was given tranexamic acid on the first day, but bleeding persisted. Vital signs were within normal range. CBC showed the WBC of 7, hemoglobin of 12.5, and platelet count was at 3,000. She denies any history of bleeding except for normal duration and quantity of menstruation. There's no intake of any other medications, denies any vices, non-alcoholic beverage drinker. The PBS, or the peripheral blood smear, showed severe thrombocytopenia, which is real, and some large platelets. Immature platelet fraction is increased at 7%, Coombs test negative, ANA, hepatitis profile, HIV screen, urea breath tests were all negative, and abdominal ultrasound was unremarkable. The IPF, or the immature platelet fraction, is a technology that measures the so-called reticulated or immature platelets, which are newly released into the circulation, which are more reactive than mature platelets. This is much like a reticulocyte count for RBCs. So going back to our algorithm, the thrombocytopenia of our patient is real and of acute onset, and it is isolated. So this is a case of immune thrombocytopenia. Although immune thrombocytopenia is the most common cause of isolated thrombocytopenia, there are no tests sensitive or specific enough to confirm the diagnosis, so it remains a diagnosis of exclusion. I usually request also for an ultrasound of the abdomen to rule out occasional initial manifestation of chronic liver disease with hypersplenism that causes the thrombocytopenia. The role of the bone marrow biopsy and aspirate in patients with isolated thrombocytopenia remains controversial. The International Consensus Report Panel recommends performing these investigations in patients more than 60 years of age because isolated thrombocytopenia may be the initial abnormality of an underlying myelodysplastic syndrome. So these are basic laboratory tests to evaluate patients with suspected ITP according to International Consensus Report. ITP can then be treated with steroids. There is a wide range of medications associated with thrombocytopenia. Although the most common presentation of drug-induced thrombocytopenia is severe symptomatic hemorrhage, an abnormal platelet count may be the first evidence of potential problems. Changes in medications over the past 10 days should be assessed. Normally, it takes at least 5 days of drug exposure to develop thrombocytopenia, but as little as few hours may be all that is required for Fibans and abscizumab, or if the patient has been exposed to the drug previously. The gold standard to confirm this diagnosis is a drug re-challenge, but of course, this is rather impractical. This table represents the most common medications implicated in thrombocytopenia and their mechanisms. The most commonly implicated drugs are quinine, quinidine, trimethoprim, sulfamethoxazole, vancomycin, linezolid, and chemotherapeutic drugs. Infections or live vaccinations may cause thrombocytopenia by direct marrow suppression and increased peripheral consumption. An isolated low platelet count may be the initial manifestation of disease, as seen in as many as 10% of patients with HIV. Some of other commonly associated viruses include hepatitis C, H. pylori, Epstein-Barr virus, cytomegalovirus, rubella virus, parvovirus B19, and mumps. So this is another case of an 82-year-old male known hypertensive who was admitted due to hip fracture. He underwent ORIF on the second hospital day and given unfractionated heparin for DVT prophylaxis on the third hospital day. CBC upon admission showed WBC of 8, hemoglobin of 14, and platelet count was at 170,000. On the 8th hospital day, however, lower extremity duplex scan showed acute thrombosis of the left common femoral artery. Repeat WBC was 9.9, hemoglobin 13.5, and platelet count dropped to 55,000. So heparin-induced thrombocytopenia, or HIT, occurs in 0.5 to 5% of heparin-treated subjects. It should be suspected in any patient who, while on heparin therapy, has a more than or equal to 50% decrease in platelet count compared with baseline, or a total platelet count of less than 100,000 with normal baseline counts. Thrombocytopenia is usually moderate, with median platelet counts ranging from 50 to 80,000, and nadir counts rarely below 20,000. Clinical manifestations may include venous or arterial thrombosis, or necrotic skin lesions at heparin injection sites. At present, it is not possible to predict which patients will develop these complications. HIT typically develops after exposure to heparin for 5 to 10 days. Earlier onset of HIT, sometimes within a few hours after the first heparin administration, occurs in about 30% of cases, and these patients have a history of exposure to heparin in the prior 3 months, thereby developing antibodies against the heparin PF4 complex. HIT is often a clinical emergency, and on such occasions, the presumptive diagnosis has to be based solely on clinical findings. Clinicians can be supported in their choices by clinical scoring systems based on the pretest probability of HIT, such as the one known as the 4 T's, or the thrombocytopenia, thrombosis, timing, and other causes of thrombocytopenia score. So for case 2, there was a platelet count fall of more than 50%, clear onset between days 5 to 14 on this patient. It's on the 6th day of heparin therapy. There is new onset thrombosis, and there is no apparent cause of other thrombocytopenia, giving her a score of 8. And based on this algorithm, for HIT, when HIT is suspected, you calculate the 4T score, and if your patient has an intermediate or high clinical probability with a 4T score of more than or equal to 4, you discontinue heparin and start non-heparin anticoagulant. You obtain the immunoassay for HIT. If it's positive, you continue to avoid heparin and continue the non-heparin anticoagulant. If it's negative, then HIT is unlikely. Do not order HIT lab testing, and continue to resume heparin if indicated. If there's a low probability of HIT, then do not order for HIT lab testing. Continue to resume heparin if indicated. DIC, on the other hand, seldom presents as isolated thrombocytopenia and is usually associated with an underlying condition such as sepsis, trauma after surgery, or obstructive complications. It is accompanied by derangement in clotting factors, among others. There is no single laboratory test for accurate and precise diagnosis of DIC. However, the ISTH, or International Society of Thrombosis and Hemostasis Committee, has proposed a scoring system using the parameters reported in this table, in which a score of more than or equal to 5 is consistent with overt DIC. The most common causes of thrombocytopenia in pregnant women are gestational thrombocytopenia, which occurs 70% of the time, preeclampsia 21%, and ITP in 3%. Gestational thrombocytopenia is seen in the mid-second to third trimester of pregnancy, and there is no clearly defined minimum value of platelet count, but counts less than 70,000 should raise the suspicion of an alternative diagnosis. There are no confirmatory lab tests for gestational thrombocytopenia, or GT, and the diagnosis remains one of exclusion. To support the diagnosis of GT, women should have no past history of thrombocytopenia except during a previous pregnancy, and the thrombocytopenia should resolve spontaneously within 1 to 2 months after delivery. A constellation of nonspecific abnormalities of WBCs are common to many conditions such as neutrophilia, lymphocytosis, leukopenia, etc., which may be associated with thrombocytopenia. The presence of dark coarse granules or toxic granulations, as seen in this picture, found in neutrophils would suggest sepsis. Atypical lymphocytes would suggest viral infection. An appropriate test for infections is warranted. Microspherocytes may suggest Evans syndrome or hemolytic anemia, and testing for hemolysis, such as the direct antiglobulin test or Coombs test, LDH, reticulocyte count, and screening for autoimmune diseases like SLE may be warranted. Macrocytosis and hypersegmentation of neutrophils, as seen in this picture, suggest vitamin B12 or folate deficiency. Check the MCV-MCH in the CBC of your patient. If it's elevated and you have bicytopenia or pancytopenia, check for B12 and folate levels. They may be deficient, and if they're deficient, you supplement these vitamins. Then you will monitor the patient if it will improve. Malignant hematological disorders like leukemia are often associated with thrombocytopenia, which is almost never an isolated finding. The peripheral blood smear will often reveal blast cells, as seen in this picture. Other cells that point to a probable primary bone marrow disorder like nucleated RBCs, the cryocytes, Pelger-Hewitt cells warrant further investigation like bone marrow aspiration and biopsy. The presence of RBC fragments, known as schistocytes with Coombs negative hemolytic anemia, is indicative of thrombotic microangiopathy, or TMA. Thrombotic thrombocytopenic purpura, or TTP, and hemolytic uremic syndrome, HUS, are multisystem disorders characterized by thrombocytopenia and microangiopathic hemolytic anemia, or MAHA. These are life-threatening illnesses, and TTP has a mortality rate of more than 90% without appropriate treatment. Let me give you a background on the pathogenesis of TTP. So, von Willebrand factor is secreted from endothelial cells as ultra-large multimers, and ADAMTS13, which is a disintegrin-like and metalloprotease with thrombospondin type 1 motif member 13, Adams TS13 for short, progressively reduces the size of these von Willebrand factor multimers as they circulate in the blood. Platelet GP1B binds to the von Willebrand factor A1 domain. Flowing blood applies force to these platelets that stretches the von Willebrand factor and exposes a cleavage site for Adams TS13 in the A2 domain. Von Willebrand factor multimers may adhere to endothelial cells or connective tissue in the vessel wall, and cleavage of von Willebrand factor limits the growth of intravascular thrombi. Congenital or acquired ADAMTS13 deficiency allows excessive platelet deposition, causing microvascular thrombosis and TTP. So for case 3, we have a 47-year-old female with a history of hypertension who came in due to fever, accompanied by generalized body weakness, easy fatigability of 3 days duration. On consultation, hemoglobin was at 65, WBC 7.2 with segmenters of 75, lymphocytes of 20, monocytes of 5, and platelet count of 16,000. LDH was elevated at 3,200 with indirect hyperbilirubinemia. Low haptoglobin, Coombs test was negative. These are all indicative of active hemolysis. Elevated creatinine at 3 milligrams per deciliter. Peripheral blood smear showed increased schistocytes, or the arrows here showing the schistocytes in this peripheral blood smear, and there is the severe thrombocytopenia. There is no abnormal WBCs noted. She claims that her CBC 3 months ago on routine follow-up with her doctor was unremarkable. So for case 3, these are the salient features: Coombs negative, microangiopathic hemolytic anemia, severe thrombocytopenia, elevated creatinine, and fever. So she is diagnosed with TTP, and immediate referral for plasma exchange is warranted. The diagnosis of TTP is based on presenting clinical features. Measurements of ADAMTS13 activity are not required and may not be appropriate for the critical initial management decision to begin or not to begin plasma exchange. It is recommended that adults who fulfill the diagnostic criteria for TTP be treated with plasma exchange. So the diagnostic criteria for TTP is microangiopathic hemolytic anemia, with or without renal failure or neurologic abnormalities, and without another cause for the TMA. Although you will be hearing or reading about decades of dogma describing the danger of platelet transfusions in platelets with TTP, the only supporting observations are dramatic case reports. And although it is prudent to be cautious, the appropriate use of platelet transfusion for prevention or management of hemorrhage is the same and appropriate for patients with TTP as in the general population. In patients with TTP, severe thrombocytopenia itself is not an appropriate indication for platelet transfusion. So we now go to the red flags in severe thrombocytopenia. So when is immediate referral required? So you look for these red flags. If there is the presence of bleeding due to thrombocytopenia from any cause, presence of blasts on a blood film, or any dysplastic changes is likely to be the first presentation of a hematological malignancy. Evidence of hemolysis with or without neurologic findings and renal dysfunction could be TTP-HUS. These are life-threatening illnesses for which early diagnosis and referral for plasma exchange should be done. Recent use of heparin or presence of skin necrosis suggesting heparin-induced thrombocytopenia. Associated coagulation abnormalities found in disseminated intravascular coagulopathy, which is a consumptive coagulopathy associated with end organ damage. And lastly, elderly patients with dysplastic features on peripheral blood film is suggestive of myelodysplasia. These are pre-leukemic disorders, which are more common in people older than 60 years of age and warrant particular attention as they may manifest solely as isolated thrombocytopenia with subtle changes on peripheral film. Before we end this session, let me review you on the thresholds of platelet transfusions. So for all hospitalized patients with a platelet count of less than or equal to 10,000, it is indicated to transfuse platelet to reduce the risk for spontaneous bleeding. Patients undergoing central venous catheter insertion, the threshold is less than 20,000. Patients undergoing elective diagnostic lumbar tap, or patients undergoing major elective non-neuroaxial surgery warrants platelet transfusion if their platelet count is less than 50,000. Patients undergoing CNS surgery, the threshold is less than 80 to 100,000, but usually use 100,000. So thrombocytopenia is a common finding and has a wide range of etiologies. A systematic approach to identifying the underlying cause is essential. Due to lack of specific tests, careful history, examination, and blood evaluation remain the initial means of diagnosis. A list of common benign causes of isolated thrombocytopenia and red flags can help the general practitioner triage those at high risk. Thank you very much for your attention.